indication for the Davydov procedure is vaginal agenesis. It may also be indicated for augmentation of vaginal length after prior vaginoplasty or radiotherapy. First-line treatment for vaginal agenesis is self-dilation with multidisciplinary support, including pelvic physiotherapy and psychologic care. When first-line treatment fails, surgery is often indicated. Surgical options include split or full-thickness flaps, buccal or intestinal vaginoplasty, the Davydov procedure, or the Vecchietti procedure. This video will focus on the Davydov procedure for the creation of a neovagina. The Davydov procedure was first described in 1969 and involved lining a neovaginal space with peritoneum. A laparoscopic approach was then described in 1993. This video presents a modification to the laparoscopic Davydov procedure. Surgical steps include first defining the anatomy, and if fallopian tubes are present, salpingectomy is recommended for ovarian cancer risk reduction. Second, create the neovaginal space. Third, line the neovagina with peritoneum. Fourth, dissect the pelvic sidewall structures off the peritoneum. And finally, suture the neovagina over the stent. Step 1. Define the anatomy. The left hemipelvis contains a normal ovary and fallopian tube connected to a uterine remnant. There are no midline gynecologic organs. Anatomic variations are more prevalent in patients with Müllerian anomalies. On the right, the common iliac artery runs deep into the pelvis before bifurcating into the internal and external branches. The ureter is underneath the common iliac artery. For ovarian cancer risk reduction, a bilateral salpingectomy is then performed. Step 2. Create the neovaginal space. Here, you can see a blind-ended vagina. The vaginal vestibulum is divided in the midline using electrosurgery. The neovaginal space is then created primarily through blunt dissection, first with a suction tip and then digitally. Laparoscopic guidance is used to ensure blunt dissection creates a space between the rectum and bladder. Blunt dissection is continued with right angle retractors and then a large diameter Hagar dilator. Laparoscopic guidance is used throughout. A rectal probe can be used to deflect the rectum posteriorly to help avoid injury. Step 3. Line the neovagina with peritoneum. A sponge forceps is introduced into the neovaginal space and used to grasp the pelvic peritoneum. The peritoneum is then pulled down towards the vaginal introitus. The peritoneum is divided with scissors, allowing access to the peritoneal cavity. It is then stretched to accommodate the width of 2 fingers. The peritoneum is then sutured to the mucosa of the vaginal vestibulum using 2O polysorb or Vicryl sutures. This is performed circumferentially in a simple interrupted fashion. Sutures are held with snaps and only tied down once all stitches have been placed. In the absence of commercially available vaginal stents, a vaginal stent 2 finger breadths wide is created using sterile gauze covered by 2 latex-free condoms. It should measure around 10 centimeters in length and 3 centimeters in width. The vaginal stent is then inserted into the neovaginal space. Step 4. Dissect the pelvic sidewall. The retroperitoneal space is opened, and the pelvic sidewall structures are lateralized off of the peritoneum. This helps avoid tension on the pelvic sidewall during the formation of the neovaginal apex and maximizes the peritoneum available to create the upper vaginal vault. The uteroovarian ligament is divided to preserve the anatomical location of the ovaries. This avoids them from being pulled medially when suturing the apex of the neovagina, unlike in the traditional laparoscopic approach. The same is then performed on the right side. The traditional Davydov procedure involved round ligament transection to prevent tension on pelvic sidewall structures. The modified approach, presented here, utilizes a more extensive sidewall dissection while preserving the round ligaments for additional neovaginal vault support. On the right, the ureter can be seen coursing deep to the common iliac artery variant. Step 5. Suture the neovagina over the stent. Using a 1-biasin or monocrol suture, a purse string stitch is run through the left uterine remnant, the connective tissue band connecting the two uterine remnants in the midline, the right uterine remnant, and then the perirectal fascia on either side of the rectum. It is then tied down with a rotor knot to create the neovaginal apex. To review the surgical steps, Step 1 is define the anatomy, Step 2 is create the neovaginal space, Step 3 is line the neovagina with peritoneum, Step 4 is dissect the pelvic sidewall, and Step 5 is suture the neovagina over the stent. The stent is left in place for 6 to 12 weeks postoperatively. Ongoing care involves periodic use of dilators and/or intercourse to prevent vaginal stenosis. Vaginal estrogen can be considered during the postoperative period. A systematic review and meta-analysis concluded that no surgical technique was superior over another. Meta-analysis of 500 patients who underwent the Davydov procedure found high rates of sexual satisfaction while only 2 patients suffered from vaginal stenosis. In conclusion, first-line treatment for vaginal agenesis is self-dilation. Although no single technique is superior, the Davydov procedure results in high rates of sexual satisfaction. And the modified laparoscopic approach preserves the round ligaments for added support, avoids tension on pelvic sidewall structures, and preserves the